You're listening to The Q Switch with your host, Spence.
Welcome, one and all to the Q Switch Conversations podcast. I am your host, Spence, and the mission of this show is to tackle subjects currently impacting ophthalmology and pull in leading eye care professionals and industry players to discuss their unique perspectives. So let's jump right on in. In this episode of the Q Switch, we are joined by world-renowned retina specialist, Dr. Randy Dhaliwal. He is the founder of the Retina Eye Center in Augusta, Georgia, and he's widely published and currently has faculty appointments at Queen's University and University of Toronto, both in Canada, as well as Johns Hopkins and Emory University here in the United States. Dr. Dhaliwal, thank you for coming on the show. Where are you calling from today?
I'm calling from my office here in Augusta.
Well, again, thanks for joining us and making time. So in this episode, we'll tap into Dr. Dhaliwal's decades of U.S. and global practice and expertise, where we'll be discussing the evolution of the vitreoretinal specialty, digging into its past, what's relevant now, and what he sees in the years ahead. So Dr. Dhaliwal, first of all, thanks for making time for us and joining the Q Switch conversation. So you've practiced in the U.S. for quite some time, but you hail from Canada. What was that career journey like for you, and what was your North Star that guided you to where you are today?
Well, I was born in Vancouver and went to medical school there, and I did most of my specialty training in Eastern Canada and Ontario and Toronto, as well as at Queen's University. And I also practiced for a brief interval on the Alaska Highway up in Northern Canada as a family doctor, that whole northern exposure experience. But it was actually some of the most valuable time I had ever spent, and it really prepared me for the rest of my career. When I returned to ophthalmology, my father, who was a diabetic in British Columbia, developed diabetic vitreous hemorrhages and fractional detachments and lost all the vision in one eye and lost 50% of the vision in the other eye. And that, combined with my medical background and experience, led me to develop an interest in retina when I was doing ophthalmology, and eventually led to a retina fellowship in the U.S. And I really had no intention of ever staying in the U.S. I went back after doing a year of medical retina at Hopkins and then surgical retina in St. Louis with the Barnes Retina Group. I returned to a faculty position at the University of Toronto. But at that time in 1992-93, the healthcare system in Ontario was going through some severe financial restrictions, and there was a lot of resource restrictions that made it almost impossible for me to practice fully to the extent that I was capable of and wanted to practice. And patients were taking too long to get in. And even though we were putting out brush fires, I felt unsatisfied with the outcomes. And I felt I wanted to come back to the U.S. where I could better use my skills at the time. The Southeast is where I wanted to come, and Augusta was one of the underserviced communities in the South for people of my specialty. And since I was a Canadian citizen, I had to still immigrate. And you've heard of the INS. I had to qualify to get a green card by coming to an underserviced community where they could not find another American to take the job that I was interested in. And with my qualifications, I got my green card 6 months after arriving here. But I really like the community. It's the second largest medical community in the second largest city in the state of Georgia. And I felt that I could provide care that would change the standard of care in the community, as well as, at the same time, have a good community to raise a family in. I wasn't married at the time, and I married my ex-fellow. She was from New York and New Jersey, and she did her fellowship with me in Toronto. And she played part of my decision-making into why I should come back south. And we got married about a year and a half after I moved to Augusta, and we have 2 daughters. And it's been a great journey.
I understand your wife's also a retina specialist too,
Correct.
right?
Correct.
And does she practice with you at the Retina Eye Center? Okay, cool. All right.
She's the boss.
They always are, man. I got a boss too. So well, you have a very compelling story, Doc. So thanks for sharing it. I hope and expect it will inspire and motivate young people pursuing ophthalmology to follow your lead. So let's move into today's topic, the evolution of the vitreoretinal specialty, its past, present, and future. To kick things off, take us back to when you first entered the field. What did the practice of vitreoretina look like then, and how would you describe the biggest contrast with today's retina clinic?
In the early the field of medical retina was largely dominated by controlled clinical trials looking into the role of laser treatments in exudative age-related macular degeneration and other retinal vascular disorders such as venous occlusive disease and sickle cell retinopathy, etc. Controlled trials at that time showed a role for controlled ablation of exudative processes to limit the amount of vision loss and stabilize the vision. And in surgery at that time, we were just getting into vitrectomy surgery becoming part of the mainstay of treatments. Prior to the late 80s, scleral buckling was pretty much the sole surgical modality we had for treatment of a variety of retinal disorders, as well as retinal cryopecty. But vitrectomy surgery, after it was developed by Dr. Mockemer in Miami, started to spread into generalized use by the late 80s, early 90s, and then it became an issue of evolving techniques. As the techniques got better, we were able to handle more and more previously untreatable conditions such as macular holes. There was even an era that when I was a fellow in St. Louis where we were doing submacular surgery to physically remove the blood vessels from under the retina rather than doing laser. And that was subsequently studied, and it was shown to be not necessarily in a controlled trial to be better than laser treatment at the time. In the late 90s, we started getting into the era of pharmacological manipulation of retinal diseases, starting off with injectable steroids, which did have a beneficial role to play either as ancillary treatment to previously established modalities or instead of. And then eventually Macugen became the first true anti-VEGF therapy that was available. However, it was later usurped by the role of bevacizumab or Avastin after Dr. Rosenfeld in the University of Miami showed that you could aliquot out small amounts of Avastin that was being used for chemotherapy at the time directly into the eye, and it had a rather dramatic effect. That really wasn't until around 2005.
Okay.
And so I know here locally, I was the first one to inject Avastin in our state for exudative macular degeneration, and Bob Avery and his colleagues in Santa Barbara also were doing it concurrently. And then Avastin became the de facto go-to treatment and usurped the role of Macugen at the time, and then subsequently other more effective, more targeted treatments became available. And in the last few years, we've been looking at longer acting modalities of anti-VEGF therapy. So we've really gone from a predominantly surgical specialty, if you view lasers as surgery, which they are, and of course vitrectomies and those ancillary procedures in the early 90s. Then it went through a gradual transition to what is now a predominantly pharmacologically based subspecialty, much like oncology.
Mm-hmm. Well, we are certainly going to get into that a little more. I have some questions that I think that'll serve that right up. But I can't say that does paint a very vivid picture of how far we've come. And let's explore that just a little bit more. So what have been some of the most transformative procedural changes you've witnessed, especially in surgical retina, from scleral buckling to modern vitrectomy techniques?
I think the most innovative thing was wide field imaging. And this came out of Germany, and the initial wide field viewing systems, as advocated by Stanley Chang and people in New York, was a contact lens with a wide field image that during surgery allowed you to get your vitrectomy performed under direct visualization. That was somewhat problematic in that you had to have a good assistant holding the lens steady while you're doing your surgery. And later non-contact wide field viewing systems came out, which completely supplanted the contact lens systems. And this has made a radical improvement in the outcomes as well as the complexity of the surgeries. In addition, simultaneously, the various manufacturers of the vitrectomy machines came out with higher and higher cutting rates. And these improved the overall efficiency of the vitrectomy procedures. So what were previously 1.5 to 2 hour procedures are now routinely 15 to 20 minutes. So the surgical procedures have become much more efficient. And lastly, the transition from larger gauge, in other words, wider openings, larger gauge vitrectomies, which were 20 gauge at the time, and now we have them down to 27 gauge. So now we don't even have to put a suture in
Oh,
at
wow.
the end of surgery. Yeah. So it's kind of like cataract surgery, where instead of making large incisions and putting in multiple stitches, we are transitioning to a point where you have self-sealing wounds, smaller gauge instrumentation, which is more efficient, both in cutting and as well as the fluid dynamics. You have wide field viewing systems. All of these things have come together simultaneously. And I think I should mention one more thing. Dr. Chang advocated the use of heavy perfluorocarbon liquids in the late
What's that?
90s,
What
which
is
is a
that exactly?
heavy liquid you can put into the eye, and it acts like a third hand, so
Oh,
that you have a means of manipulating the retinal tissue and while you're operating on it, and you can make incisions or holes in the retina if you need to, and you can lay the retina flat. You steamroller it flat, then you can apply laser and then remove the heavy liquids. And subsequent to that, the introduction of long-lasting tamponade agents. Instead of using short-acting gas bubbles, we then transition to longer lasting gas bubbles, and then finally to the use of silicone oil, which can stay in place for a period of months, even years,
mhm.
and then be removed later.
Yeah, well, with all these tools evolving, some techniques have stood the test of time. I think one of those, as you mentioned earlier, being lasers. And lasers, as you know, have been a cornerstone in retina care for decades. How has the role of lasers changed over time, particularly with the rise of, as you mentioned, anti-VEGF therapies and newer surgical tools? And where do you see lasers still playing a critical role in today's vitreoretinal practices?
Laser still plays a role. There are certain types of exudative macular degeneration, particularly where the blood vessels arise off the edge of the optic nerve, that actually do very well with a single laser session, and you can involute the entire process and not impact the central vision. And it can also be used very effectively with venous occlusive diseases like branch retinal vein occlusions. And of course, in diabetics, although you can control proliferative disease in diabetes with monthly injections of anti-VEGF therapy, or in 2 or 3 laser sessions, you can basically completely involute the disease and obviate the need for injections. If you have people who lead busy lives, a lot of times the laser treatment is preferable to the
Right.
injection. Also, if you have people coming, as we have some from some of the smaller towns in Georgia and South Carolina, who come a long ways to be seen, just the logistics, the treatment burden to get to the doctor's office for the injections can be overwhelming. But if you can involute the disease and bring them under control with 2 or 3 laser sessions, problem solved. And of course, you always have the non-compliant patients, in which laser treatment is preferable to injectable therapies, because you at least get the patient treated while you have the chance.
Hmm. Yeah, I've heard that from a couple of retina folks with that population of patients that you just listed, the ones that are hard to actually set appointments for because of their distance, or just patients who aren't that compliant. When you got them,
I,
treat them.
I've had, I can give you an example of one young lady. She was
Hmm.
27 years old from a very small town in South Georgia, and she needed to have her panretinal laser treatment done, but she had a $15 copay. And for some reason, she found that onerous.
Hmm.
So she failed to keep her follow-up appointments. And she disappeared for 4 or 5 years and came back blind bilaterally.
Oh goodness.
It was tragic. And of course, the $50, $300 copay she would have had with certain injectable agents would have been insurmountable to someone like that. So laser treatments are a very useful adjunct. As I might add, is peripheral cryopexy, which is also
Okay.
a good adjunct. That's a dinosaur treatment, but properly applied and in the right settings, it can really augment the role of both anti-VEGF therapy and laser. And lastly, laser is invaluable during vitrectomy surgery. in people with proliferative disease, people with retinal detachments, the role of the endolaser, the laser probes where you can deliver directly during the surgery. It's just revolutionary.
Well, you over the course of your career have it sounds to me like you've had a pretty easy time adapting to innovation. Some of the things have been introduced to retina to better perform the procedures and provide a higher level of patient care. So, as a veteran in the field, how did you personally adapt to these new tools and paradigms? And were there moments where innovation felt more disruptive than helpful?
I think for me, part of it was just good timing. Had I done my fellowship training even 5 years earlier, it would have been more difficult to transition. But a lot of these agents that we were using experimentally, I was using during fellowship.
Hmm.
And also some of the things like the perfluorocarbon liquids were already approved to be used in places like in Toronto when I was there. And in fact, I used to smuggle it across the border and use it here until it finally got approved by the FDA. And so I was able to do hundreds of cases before it was even generally approved for use in the US. And so part of it was just good timing. Part of it was just a large volume of surgery. You know, coming to a smaller city, you're not a squirrel looking for your nut like you would be in a larger city where there's 50 other people doing exactly what you do. And you're one of a very small number of people offering that unique service to a relatively large population. In our case, we service almost 1 million people here. And so,
Wow.
and the fact that it was so underserviced is remarkable. But there were so few people being trained back in the early 90s that I guess that's responsible for why it was underserviced. And thankfully, because it gave me my green card in 6 months. But I think that being that we were doing Canadian volumes of surgery in a US setting allowed me to develop and modify my techniques over time. And after you've done 10,000 of these, you become pretty good at it.
Hmm.
And you can
Hmm.
adapt readily. It's like you can hand me any instrument and I can adapt to it because I'm so comfortable doing it. I think for people that are just starting the specialty, it takes a while to develop those skills and become proficient in them, but that's true of any surgical endeavor.
So I want to revisit pharmacological advances.
Sure.
And you mentioned it earlier that one of the biggest shifts has been in the pharmacotherapy, especially with anti-VEGF agents. How did these drugs reshape your management of retina disease like AMD and diabetic retinopathy? If you want to add anything from your comments earlier.
Well, obviously, they give us better outcomes. You're not leaving laser scars so close to the center of the vision, and hence there's very little collateral damage. And so this is obviously a benefit to the patient. Secondly, the newer agents being longer acting allow us to treat more patients and not place a heavy burden on the patient themselves. And of course, with fewer injections, it also means less exposure to complications such as in infections, which can and do occur. And so the anti-VEGF therapy has really revolutionized the field of retina, and and I think has enhanced the population health overall, or at least their visual health.
Mhm. And and I would say, and yet with all that progress, with all these different advances, both surgically and pharmacologically, if I can say that right, even with these powerful therapies, I'm sure there's still challenges that are faced in the specialty. So, what persistent clinical or systemic challenges do you and your colleagues still face today in the vitreoretinal space?
Well, we continue to refine our role that these anti-VEGF agents play. I think, as an aside, one of the major impacts I've seen is more socioeconomic, in that the anti-VEGF therapies, as they've improved, we've developed bigger, better, longer lasting, and more expensive drugs. So now you introduce the whole issue into the retina realm that the oncology people faced a decade prior or 2 decades prior, where suddenly you start getting into the incentives and disincentives associated with the use of each of these drugs.
Hmm.
Incentives meaning, of course, profitability to the core business of running a practice. And it challenges the practice because you're dealing with millions of dollars of drug flow. And this drug float requires monthly infusions of hundreds of thousands of dollars. So it requires that every part of your organization has to be efficient, and your collections have to be efficient to meet the costs of the drugs as they come in. We recently had a once in 200 years ever a hurricane come through Augusta. It was devastating. I mean, the news was on Asheville, North Carolina, but Augusta took a direct hit, and the power went out for a week. And in our refrigerator alone, there was $1 million worth of drug that had to be discarded. So again, that's a logistical business related issue. Another issue, of course, as I said, is not only staying on top of the payments and meeting your drug float, but if you're efficient at it, and Dr. Demiduke and myself, my wife and I, had a very tight revenue cycle, and we were able to stay on top of this. And we were injecting around $13 million a year of drug. This was up 2 years ago. But we found that the small percentage of money that you are allowed to keep as a practice for each injection, that very small differential adds up. And what happened is over time, more and more injections have been given across this country. 250,000 injections in the next year after Avastin became introduced. Then the next year it was 500,000. And the fastest growing expense in the Medicare budget is injectable drugs for retinal related cases.
Is that right?
That's right. And also then the drug companies wanted you to push their specific drug, and they would give incentives to groups for the more drug you inject, we'll give you a larger discount. And you're allowed to keep that discount as opposed to passing it on to the drug company. And so it incentivized larger and larger groups to form and incentivized groups of existing retinal specialists to hire more and more retinal specialists. Suddenly you have this entire field of medical retina become, as opposed to surgical retina, become a valuable thing to these practices. And they grew almost exponentially. And the base salaries of these new people coming fresh out of fellowship was then double, triple, quadruple what people were being paid to come out of fellowship only 15 years prior. So this really perversely affected the allocation and distribution of practicing retinal specialists in this country, concentrating them into larger and larger groups. And it also made it harder for the smaller groups to hire somebody new because they weren't getting those discounts because they weren't pushing quite the volume.
Right.
Because if you have 6 or 8 retinal specialists in a group, you're talking $40 million or $50 million a year of drug. And,
Right.
and even a small percentage of that is a significant sum of money. And you can afford to pay an exorbitant, overinflated salary to someone fresh out of training with no experience. And so it altered the practicing landscape in this country. And it's exemplified by a recent situation where a lot of these expensive drugs, like, for example, Vabysmo, for example, it's a $2,500 per injection. And their insurance would cover 80%, and the remaining $400 was covered by a charitable organization called Good Days. And Good Days is a true charitable organization. Federal government recognizes it as such. And they provide copays for people that are cancer patients and people also that were using injectable drugs in their eye. So that was being subsidized by this pure charity that was being funded on the back end by not only individual philanthropists, but by corporations. Like a Regeneron gave them $1 billion a year.
Oh, wait. Wow. Okay.
Yeah. And this year, it didn't get funded. So suddenly, we were only 2 or 3 months ago, we were facing a situation where you're taking the person who's living off their Social Security check and telling them that if you want to continue getting this medication, you're going to have to pay us $350 or $400 every time. And that may be as frequent as every 5 weeks or
Wow.
out
So-
to every 8. And so they have a choice of either eating or having their medication.
I was just about to say that makes some tough choices, just lifestyle choices. Do I, do X or, it's the lesser two evils. You got to eat,
Right.
but you got to see, so it makes
believe,
some
though,
very difficult, challenging decisions for a lot of folks out there.
My colleagues in Atlanta, in San Francisco that I've spoken to, we're all facing this quandary. in our
Mhm.
special this spring. And many people are viewing it by giving the people that absolutely need it free samples that we do have a small supply of, but also sometimes switching to less expensive drugs that the patient's only out of pocket $15 or $50 versus using the more expensive drugs, but they
Mhm.
may not be quite as effective. So it creates a moral dilemma for the practitioner. But it also may have, and I'm concerned that it's going to also have secondary ramifications for the profitability for these large groups and the pay scale of future new young doctors coming out. It'll be obviously not as awash in funds as
Mhm.
it has been this past 5 years. Does that make
Well,
sense?
yeah, it certainly does. And you mentioned, new trainees, folks fresh out of training, out of fellowship and so on. I mean, you have a pretty, rich history with academic centers with either as faculty, adjunct, lecturer, and so on. So I'd imagine over the course of your career, you've mentored and trained countless young retina surgeons over that period of time. How has retina fellowship training evolved, and what are the critical skills today's trainees must have that weren't emphasized in the past?
Well, first of all, I think more time needs to be spent in fellowship discussing practical business aspects of a retina practice. And it becomes more important in an era where even slight miscalculations can lead to pretty dramatic shifts in your financial viability. So I think nobody likes to talk about the money or the business side, but it is an important facet. For me, I learned it when I was a family doctor up on the Alaska Highway. I had to
Of
run my
course.
own business, had to pay my taxes and overhead, but it became second nature to me. But a lot of young people are quite naive about that. I think another thing that's happened is because with the rise of the need for more medical retina people versus medical and surgical people, we have a proliferation of fellowships. And the fellowships are variable quality. I mean, you have good academic based practices or large private practices in major metropolitan centers where a large volume of pathology comes through, both medical and surgical, where they get lots of hands on experience. Then you have people doing one man fellowships. You know, they have one attending, could be in an academic center, could be private practice, but they don't get enough variety because those people are oftentimes in a big city where there's 70 other people doing the same specialty. Therefore, the exposure to the pathology um, is not there. So we have more younger people that have less exposure to pathology. Does that make sense?
It does. Yes. So, speaking of the next generation, let's look forward to what's coming. Looking ahead, what emerging technologies, whether AI guided diagnostics, gene therapy, or robotic assisted surgery, do you believe will redefine the specialty in the next decade?
Well, those are all things that are going to affect us. I think the field of medical retina, which is predominantly a field where there's based on pattern recognition of diseases and constellations of findings, lends itself very well to AI. And I think the AI explosion is going to affect that. It's going to affect younger medical retina people in that they're suddenly potentially displaceable, much like radiologists are vulnerable
Hmm.
because of AI. So much of what we do in medical retina is image based with optical coherence tomography, which
Right.
itself is improving and becoming more accurate. And because it is also a patterns based procedure, AI can overtake that realm. And I think will eventually speed up our processing of patients and automate the whole process of
Hmm.
medical retina. So the medical retina practices or practitioners could be relegated to the role of almost a technician, working in concert with the artificial intelligence
Hmm.
sector. In terms of surgery, I think robotics is a definite possibility. I think robotic surgery can allow much more detailed, much more accurate surgery. And I think that it's already prevalent with general surgeons and urologists and people like that, but it's coming to the microsurgical realm. And I
Hmm.
think it's going to happen before we know it. So that's another area. But I don't think it'll, in the operating room, that it will displace the surgeon because you still need the surgeon to run the robotics.
Of course.
But it's certainly those people that have a tremor or a coffee tremor will be probably happy about it. And it may speed up the procedures and allow for smaller incisions. And, it has the potential to add a lot to what we do as retina specialists.
Mm-hmm.
And
Mm-hmm.
I'm trying to think I think the pharmacological realm, we're going to see advancements where you have not a single target for the anti-VEGF therapy, for example, but multiple targets that are going to be combined in single injections that will last many months. So people will only have to come in 2, at most 3 times a year for an injection, rather than the frequency in which we're doing that now, which will again decrease the demand for larger numbers of medical retina people. I think in retina, the medical retina field is the most vulnerable to these advancing technologies.
Mm-hmm.
I think the surgical field will remain intact. And finally, the government has been significantly chopping the reimbursements to the surgical component of what we do. And hence, people were making more money on the injectables, and therefore there's a disincentive to perform the surgery that you spent years honing your skills for, and they've incentivized instead the injectable route through government meddling. Like in Canada, social engineering never works when the government gets involved.
Mm-hmm.
And I think that if they continue to do this, it's going to be more and more difficult for patients to find surgeons to do their surgery.
Mm-hmm.
One of my colleagues up in Minnesota, when they slashed the fees, for example, for surgical reimbursement on retinal detachment surgery, found that in the outlying communities, when someone came in on a Saturday with a retinal detachment, that the local retinal people didn't feel inclined to give up their time with their family on a Saturday to go into the operating room and tie up the entire afternoon, but would instead encourage the patient to go to the next slightly larger community and have it done. And they were similarly disincentivized to make it available. And they kicked the can down the road till finally they deposit themselves in Minneapolis. And these guys get dumped with large volumes of surgery that nobody else wanted to do.
Mm-hmm.
So there has to be some open communication between the specialty and the government payers so that there's more fair reimbursement, so that people stay in the game and make our services available to the community. Because ultimately, that's what it's all about.
Understood.
So those are, again, I'm veering off the technical and getting into the socioeconomic, but truthfully, they're all interdependent and they affect each other.
Of course. Of course.
At least that's my perspective over 30 years.
And after 30 years in retina, what would you say is the single most important lesson you've learned about delivering high quality patient care? And what message would you share with your younger retina specialists just beginning their careers today?
It's all about the patient. Perhaps it's a harbinger from my family practice days when I used to be Mr. Northern Exposure there. But I get to know my patients, especially at the very outset. And I find I learn the most from my patients. And I think also getting to know them, they can sense whether you've got some skin in the game with regard to their care. And I find that trust that you gain back as a physician is very, very important. And I think over the past 30 years, I believe in basic principles that I learned when I was 19 years old and beginning medical school. Patient comes first, respect them. Like I was told when I was younger, dress like your best dressed customer and wear that white lab coat. You're dealing with an older population. They expect you to look like a doctor. Don't come in with an open collar tennis shirt and running shoes. And because then you don't look like a doctor and they're not going to respect you. And so I get back to core principles more and more as time goes on, even though I have the ability to offer them so much more than we could 30 years ago.
Mm-hmm. Mm-hmm. Well, Dr. Dhaliwal, I will say, I really look forward to having this episode with you, and you did not disappoint. Your insights were thoughtful, and given your background, you are about as credible as they come. So you certainly made the difference today for many people who will be tuning into the show. Before we sign off, if a member of our audience wanted to connect with you on today's topic or to learn more about you or the Retina Center, what is the best way they can reach out and contact you?
They can email me.
And what's that email?
I would use Dollhouse, DHALHOUSE. That's a play on my last name.
I saw that. That's clever. I like it.
Gmail.com.
Fantastic. So one more time, so it's clear.
DHALHOUSE at gmail.com. But put a note in the header of the email that question following podcast. And that way, at least I know it's not spam mail or junk mail.
Yeah, I'm sure you get inundated. So, as always, we'd like to thank Riverside FM and Passionate Media for making this show possible. That's a wrap for this episode of the Q Switch Conversation podcast. Until next time, this is Spence, and I am out.